we should give. The maternal complications also, I think Komal is going to touch upon about like chorioamnionitis and all what we are worried about. So I'm really glad to be a part of it. I think in my tenure, we will add upon many stalwarts and many topics into that. I just want to bring in around some master classes also in KCOG. I mean, in talk with all the three people of KCOG office. So thank you very much, Dr. Muralidhar Pai. And really, I'm very glad that today Komal is with us. And she's my dear friend also. And she has done wonderful work as her tenure as medical disorders of pregnancy FOXY. So that committee has done wonderful work. Thank you. Over to Komal for his excellent talk.
Dear Komal, you may please upload your CV and upload your presentation, and we can start off.
Yeah, thank you. Thank you so much, Dr. Muralidhar Pai sir, Dr. Vidya Tobi. And I must say, I may congratulate Vidya Tobi for also being the president of KCOG, but she has also been a chairperson before me, and she was a recipient of the Best Committee Award. And after her, I have received. So I'm really happy that we two are always doing good work, and congratulations for you. I was present for your installation as a president at with Dr. Durga Das organizing such a beautiful program. I congratulate you and Dr. Rajeshri for taking over the reins of KCOG. And topic which I'm going to speak today is on premature PROM, current and emerging strategies. And at the outset, my sincere thanks to the Dean of KCOG, Dr. Hema Divakar, Chairman, Dr. Muralidhar Pai, Dr. Basavaraj Sajjan, Vice Chairman of KCOG, Dr. Vidya Bhatt, Secretary KCOG, and deepest regards to MJ Hiramat sir, who's the patron. I am so happy that I had visited Hubli during his tenure as Vice President of FOXY. It was a lovely experience. Sincere thanks to Dr. Nagaraj, patron of KCOG, and Dr. Suman Gaddi, the treasurer of KCOG. I think the new team with Dr. Vidya, Dr. Rajeshri, and Suman are really going to rock, and I wish them all the best. And let's begin with today's topic. So if you change the way you look at things, the things you look at change, and we really need to make our insight when we look at these patients with PPROM. And coming to the definition by textbook, the rupture of membranes with leakage of amniotic fluid in absence of uterine activity is termed as PPROM. It can be either a preterm PPROM that happens before 37 weeks, and term it will happen at 37 or after 37 weeks. So we really know that when we are talking about 8% of the term pregnancies usually will have this PPROM, and it complicates, out of which almost 8% will have some problems also, complications related to it. So etiology is usually mechanical, infected, and constitutional. Patient will give a history of PPROM in previous pregnancy, so that becomes a history-based high-risk factor. Then there can be infections. Like sometimes there can be infections which can be clinically evident, like chorioamnionitis, which can weaken the membranes, or it can be subclinical infection, maybe a urinary or a local infection, which is the ascending infection. Antepartum hemorrhage, if it is there, if it's accompanied, and then we see that this patient will end up into rupture of membranes. A weak cervix is said to be it prevents the ascending, it prevents as a barrier, and the ascending infection can actually go up, and localized biochemical weakening is caused. And because of the weak cervix is one of the factors for PPROM, and then being the smoking or something related to smoking, which is actually associated with PPROM. So how will you evaluation? Evaluation is very, very important, because we know when we have something which is going to happen so unexplained during the course of pregnancy, it is going to increase the maternal and fetal outcome. So history, almost 90% of patients will come with a gush of fluid. They will say that there is some fluid right discharge with recurrent dampness which they feel, and this may not be associated with pain, but a classical history is quite there. So after a history, if it is not very classical, and sterile speculum examination, patient needs to rest. and then you find the amniotic fluid which is pooling. You put a speculum and you gently apply a pressure, funding pressure, and see if there is fluid which is just coming, and you feel that there is a like fluid coming, then you know that it is a rupture of membranes. Meconium, if there is rupture of membranes with meconium, it becomes actually difficult, easy to diagnose. There is no difficulty, but the plan of management completely changes, because here you cannot do an expectant management. Also, the length and dilatation of cervix, because if suppose it is a rupture of membranes with initiation of labor pains, then you will see changes in the cervix, the dilatation and phase. Digital examination. This is a very important factor, that whenever we get a patient for PPROM, we know that if we do frequent examinations, there would be incidence of chorioamnionitis, postpartum endometritis, and even neonates will have a long-term NICU course, because the antibiotic and neonatal sepsis will increase. And also, if you're planning to conserve a patient, 2 recurrent per vaginal examination will not allow, because patient will go into sepsis, and then that will be one of the indications to terminate the pregnancy. So we really need to be very careful by digital examination. Avoid unless the patient has strong uterine contraction and you feel the patient is going into labor, or you feel clinically the patient requires a per vaginal examination. So judge and then do it. What about the investigation? Simple investigations, we can tell the patients to keep pads and then check if the pads are getting soaked up. So this becomes a very simple method which can be followed anywhere. There are also pads which change color because they come into contact with fluids, and then we see the pH change in them. Nitrazine sticks are also available. These are the sticks which depend on the high alkaline pH of the amniotic fluid, and you really need to rely on the liquor, and these are little strong, and we can actually detect leaking with the help of this trick. But the only thing is they may not be available at every center. Then coming to the ferning pattern. Ferning pattern is that when the amniotic fluid is dried onto a glass slide, and you can see this typical ferning pattern on a microscope. But what happens is that this is not very reliable, because there can be false positive as well as false negative weights of the ferning pattern. Then coming to fetal fibronectin, this is also been summarized that this is usually a assessment for prediction of preterm birth and not for PPROM. And here there can be it only depends. It is a relative marker, because the fetal of fibronectin has to be present in the cervical secretions. So which will not be present if the gestational age is very early. So this is also a relative marker and not very strongly recommended. Then coming to something fancy, that is AmnioSure, but the only thing, the sensitivity being good, but this is costly thing, and like a swab stick needs to be inserted into the vagina, and then you put it in a fluid which is given and check on a control strip. And this is like our pregnancy test, where you can interpret results in 5 to 10 minutes. And when we check that there are 2 lines like this, you know that definitely this is like and there is leakage. But when we talk about all these things, the cost becomes a factor in our country, and we really don't want we want a sure of a diagnosis. We don't want a query diagnosis, and we don't want to rely on substances like fetal fibronectin or insulin like growth factor, or alpha microglobulin, all these. So we don't want to depend. So clinical diagnosis becomes the foremost. And ultrasound, we always say that after examination we subject the patient to ultrasound. So can ultrasound be a primary diagnostic tool? Not really. Ultrasound is not for diagnosis, but for the progression of the disease, to know if there is an oligohydramnios which is going to happen. If the symptoms are still persisting, we really need to know the volume. So at that time, the amniotic fluid volume will be really, really very essential. So it has a limited value as a term, but a PPRA for prognostic effect, definitely we can do an amniotic fluid volume by serial scans. So this is the guidelines, Green Top guidelines. They said strongly that ultrasound has a not so clear assessment, not so clear in diagnosis, and the recommendations are evidence is poor, but the first speculum examination holds higher in the recommendations what are there. So management, we know if the patient is at term, we don't want any infections. So we analyze the risk of delivery is better than prolonging the pregnancy. The more you prolong, there can be more intrapartum complications, more operative delivery, and postnatal morbidity. So all the Cochrane, there are so many studies where they have analyzed the active versus expectant, and they found no increase. There was no difference in the C-section rate, and when the patient was induced early, when patient appearing at 37 weeks, there was reduced risk of chorioamnionitis, endometritis, and neonatal outcomes were also very, very good. So induction definitely holds good if the patient is at term, and expected management has its own flaws. It increases the 3 to 4 times the risk of neonatal infection. So now when we're talking about PPROM, what does the management depends upon? The first thing is the fetal well-being is the most important factor. Gestational age, then the maternal conditions, and top of it, a good neonatal setup. And all these parameters needs to be discussed with the parents. They need to know what management is there, which center is equipped. So all the counseling, this needs to be all these points needs to be counseled to the patient when they come for admission at any setup. And the principles of management will depend, the steroids being the first, antibiotics, magnesium sulfate, in utero transfer, and at times tocolytics to tide over the transfer. And then we have to get the optimum action of magnesium sulfate and steroid. So we want to prevent the risk factors, chorioamnionitis, and what test we will do is WBC and a CRP. That is what is recommended, and we can do it serially to see if the patient, if there is any clinical problem in the patient, this test can be repeated. Ultrasound to rule out oligohydramnios, and a swab test, a high vaginal swab to rule out the organism. And chorioamnionitis can be diagnosed very nicely. There is a maternal pyrexia. We see readings in 1 or 2 times with tachycardia. The tachycardia will also reflect as a fetal tachycardia with uterine tenderness. The CRP level will be raised, and there can be offensive discharge. So we really know that this patient is developing into chorioamnionitis, and we need to step up our antibiotics for this patient. Also, we need to have the risk like the ultrasound measurement of the Liker pockets. If there is an abruption, that needs to be ruled out. If there is a high leak with the membranes absent, we are worried about the cord prolapse complicating and the more chances of operative delivery. So these all will be the complications of PPROM. Coming to the guidelines, what they say about the steroids. Steroids hold a very, very good guidelines. They should be considered between 34 36 weeks of gestation before, and they definitely reduce the risk of respiratory distress. And there was no significant increase in the maternal sepsis, because we are worried about giving steroids and maternal sepsis. But in fact, we have evidence to say that steroid needs to be given, and it is really, really recommended for every gestational age. A good quality of evidence holds good. What about tocolysis? It is relatively contraindicated because tocolysis actually was associated with increased risk of 5 minutes Apgar score less than 7 and increased need of even ventilation. So if woman is before 34 weeks, even tocolysis can even increase the risk of chorioamnionitis. So we really need to be very judicious when we give tocolysis. Tocolysis only to tide the actions of our steroids or magnesium sulfate. The antibiotic by all recommendation, erythromycin should be given for 10 days following the diagnosis of PPROM. It can be 250 milligrams UID, and this is the standard antibiotic by all guidelines, and it is having a good recommendation or a good quality A recommendation with grade 1 evidence. Usually the organism is associated with group B streptococci, and that responds very well to erythromycin. But you should, after completion of 10 days, further antibiotics should be actually withheld when you are even monitoring the patient or prolonging our pregnancy, unless there is any labor or any clinical other signs. And antibiotic can be as per your center. Erythromycin by guidelines, but even like ampicillin, amoxicillin, all hold very, very good. And in complicated cases, if you feel that the patient is having a high risk factor or an immunocompromised state, you can then add as per the culture or step up the antibiotic. Uterine artery Doppler and biophysical profile. So its value is not actually effective for identification, but for monitoring of fetal growth, because after PPROM, you will find a fetal growth restriction. You have prolonged the pregnancy, but this pregnancy requires good monitoring. And this monitoring can be done by means of Doppler and biophysical profile. The role of magnesium sulfate, as I already have said, it has a very strong evidence to give magnesium sulfate to patients who are around 30 weeks. And a very strong evidence, almost RCOG and all guidelines, Green Top guidelines, they all said that magnesium sulfate at 30 weeks to be given. And magnesium sulfate does help because it reduces the severity and risk of cerebral palsy in neonates. And a loading dose of 4 gram IV bolus over 20 minutes, followed by a maintenance dose 1 gram per hour for 24 hours until birth, whichever occurs first. And you need to same way monitor the respiratory rate, the patellar reflex, urine output, as we do for our preeclampsia patients. And continue magnesium sulfate, give the patient the benefit of neuroprotection, and follow a delayed cord clamping. And this will really benefit our newborns, a patient. Talking about the pre-viable PPROM, this happens really very early now. We know that the age of viability or termination of pregnancy also has been limited, and we have extension till 24 weeks. But sometimes we have really precious pregnancy, and we come across patients who are really too premature and they come with rupture of membranes. Here, there are risks like pulmonary hyperplasia, which lung development is, it can get affected, and we can predict this on an ultrasound. Chronic pulmonary morbidity or fetal limb contractures. And this extreme premature patients, many parents will, if they're counseled and they say that it is too, with all the complications, they may opt for termination. But sometimes we have our IVF pregnancy, or we have a really precious pregnancy or elderly patient, and they may not be keen for termination. So there are so many studies which have come about role of amnio infusion in PPROM. It did hold a good evidence with a strength B, but and said that amnio infusion may prevent umbilical cord compression, postural deformities, pulmonary hypoplasia, and uterine infection. But there are not many trials. The trial or the studies are not very vast. So that is the reason we require a good amount of data to come to the conclusion. And that is the reason we do not recommend amnio infusion that routinely to our patients, because we require more studies on this subject. Then talking about now the patient has PPROM, you have managed the initial course. Now we have admitted the patient in-house. So should we continue an inpatient or an outpatient care? So the first 48 to 72 hours, definitely an inpatient care, because many patients will go into labor or they may have infection. So we really need to hold that infection. But if the patient has got stabilized after 72 hours and the patient is really very good, there is no leaking and doing very good, then outpatient care may be decided. Here we need to just counsel the patient, inform the risk, tell patients to come for follow-up, ask them about checking their temperature, educate them what are the signs, are the warning signs of chorioamnionitis which we just spoke, and tell them that if you have any foul smelling discharge or any fever or any abnormal pain, and you need to follow immediately, or there has to be a time to follow for this patient, maybe a week, 10 days, where they can repeat their count or CRP if required. So can this patient be monitored at home? And the evidence says that we need to make an individual based choice. It is not like we need to tell every patient to go at home. It all depends upon how well the patient can monitor at her setup and what is the education level and how she is comfortable. So the choice needs to be given to the patient. And if patient is staying close by and can follow up properly and follow all the advice, we can give them the choice of monitoring. Then when to deliver? This becomes after we have conserved, we have achieved everything. But what is now remaining is really the small thing, the question, should we take this patient till complete term if the patient is doing well? So what the author, these are the almost a Cochrane study by the Green Top guidelines, almost 3,600 women. And they say that there is no contraindication in continuing the pregnancy. Everything is going good with the expected management with careful monitoring. if you deliver her too early, beyond at 34, you feel that you have crossed 34 and you want to deliver, it increases the chances of respiratory distress syndrome and also an increasing rate of cesarean section. So really you need to draw a line that you don't have to hastily deliver, but if the patient is doing very well, you can actually prolong the pregnancy. And this is appropriate time to deliver. In all guidelines, they said 37 weeks, we can actually wait. There is no contraindication. We can pull on till 37 weeks. And then you're sure about the fetal maturity and you're sure about the good neonatal outcome. So we can reassure that patient and deliver after completing the expected management, which we have offered to the patient. But still, you need to take an individual decision as per how the things are progressing with this patient. Then the PPROM, which has happened between 34 to 37 weeks. Now this becomes actually you have to outweigh that whether you want to manage it by conservative means or you want to deliver. And here, if you deliver, there is less days of hospitalization because you will not discharge a term patient because she can go into labor anytime. So less hospitalization, less infection, both perinatal and neonatal and even maternal. So I think the induction and delivery holds very good. And here, when the labor progresses, you need to minimize the examination, and you really need to augment the labor between onset of labor and monitor the labor. And how will you augment? Oxytocin can be given, and it holds very good by WHO guidelines. Oxytocin is the first option for induction of labor in women with pre-labor rupture of membranes. And prostaglandins usually will only prolong what does the guidelines say, that you have induced prostaglandins, you need to wait for their action. So if you feel it's a good inducible, oxytocin holds good for this patient. Also, misoprostol, the oral or the sublingual, is a very good option because it has a low cost, and you can give even vaginally or orally misoprostol in a small dose, that is 25 micrograms. But we really require good evidence and good study. But if there is a scarred uterus, really we need to be cautious, and misoprostol is not recommended. So at the end, I'll conclude by saying that term PPROM is usually a reflection of normal physiology, whereas pathological process such as infection, antepartum hemorrhage often underlie PPROM. We need to have an accurate diagnosis of membrane rupture. This is very, very important, and a simple history and a speculum examination is so important in this patient when they present initially. A digital vaginal examination should be avoided unless we suspect a patient with PPROM going into established labor. So after PPROM, the management, we are more concerned about the fetal maturity, so steroids and antibiotics because of infection. So two main factors which are there, that is infection and neonatal lung maturity, and maternal steroid will reduce respiratory distress syndrome. And whenever there is an opportunity, if it is a very, very early PPROM, 30 weeks, magnesium sulfate, do consider it gives good neuroprotective benefit. And the most important, if you feel that the center is not well equipped, counsel the patient and transfer them to a center which has a better neonatal care unit. So patients are assured about good outcome, and in utero transfer holds good for that. So I would just end by saying no one can go back and make a new beginning, but anybody can start today and make a new ending. So let's make a new ending and give a good outcome to our patients with PPROM. And at the end, I would request all the members of KCOG and all who have joined today, I seek your blessings for the post of Vice President of OPSI from the West Zone. I have been working very actively as a chair of Medical Disorders in Pregnancy Committee. The nomination time is going on. I request you to nominate from your society and vote when the voting begins in the month of August. With that note, thank you so much for your patient hearing.
Thank you very much, Dr. Komal. It was crisp yet very comprehensive. You touched upon all the aspects of PROM, and I especially liked your last slide, which is very, very apt for this particular problem in obstetrics. PROM is almost considered as point of no return, but then yes, we can go ahead, if not, we can't go back, but we can go ahead and give a better outcome by giving neuroprophylaxis to the child and also making sure that the mother doesn't get into chorioamnionitis. And that was really, really very good talk. I request now the Secretary, Dr. Rajeshri Paladi, to handle the question and answers, if any. Over to you, Dr. Rajeshri.
Hello.
Yeah. Dr. Rajeshri, you are there?
Can you hear me?
Yeah, we can hear you, Rajeshri.
Thank you, sir. Thank you, Dr. Komal Chauhan, for the very, very informative talk about PPROM and a practical problem which we all come across in the day-to-day practice, that once there is a leak and then we have to time the duration of the pregnancy, and definitely there has to be a result. Maybe we try to keep pulling it on for a few days or a couple of days, but not beyond. And that is wherein all our expertise with the combined approach of the NICU management and the obstetric management comes into play. Thank you. That was a very, very nice talk, short and sweet, but yes, very informative, as Dr. Muralidhar sir has said. I think there are no queries. One question is there any role for preparation by Dr. Ashwin? Ma'am.
Yeah, your voice is cracking. I can read this question. See, Emna, is there any role for preparation like Forisil to prevent leak?
Yeah.
Yeah, so I think one should not introduce, these are all now coming up and we require more studies on all these preparations because they are not mentioned as widely accepted things. And introducing something, preparation to seal the leak, because we need to diagnose the leak where it is. So that becomes a very important, it may be a high leak. So if you're not able to diagnose a leak, it's very difficult to introduce and something inside that also can be a focus of infection. So we require more amount of studies on this preparation before we start putting it into our practice.
Thank you, ma'am.
Any role for amnio infusion, Dr. Komal?
Yes, actually amnio infusion I just touched upon in the topic. And amnio infusion, there are some studies which are there, and they have done amnio infusion because it helps in the lung, hypoplastic lung and limb contractures, because these become a matter of concern for a very early PPROM. So
Yes.
amnio infusion was said to hold good, but we don't have that many studies supporting,
Yes.
because we may have a pregnancy loss also occurring with amnio infusion. So we need to outweigh the advantage and the benefit of doing the procedure. Somebody who is very strongly want to continue and wants to try every good. So with good counseling, there are some cases where amnio infusion has worked.
Yeah, but moreover, amnio infusion can have, as you said, its own set of problems.
Ma'am, what about your experience of high leak? Sometimes we see that at 18-20 weeks there is a high leak, then it skins off.
Yeah, so I had many patients. Actually, I'm getting so many PPROM patients. So the high leak is there, and if you feel the leak seals off, So there is one good thing about, if the leak is high leak and it just happens and it seals off, you just need to prevent infection. These patients do good even if the liquor comes little less, and later on the liquor will become normal. Yeah. So liquor.
Please mute everyone. Arun, please mute everyone.
So what happens after that? The leak stops, and if you have been successful in preventing infection, then you can very easily prolong that.
May I request all others to mute, please? Yeah, actually, we had a similar case who came with the leak at 24 weeks in Manipal, and she was really having a very precious pregnancy, and there was no way we could allow her to abort. We admitted her, kept her in the hospital throughout, And of course, we gave a foot end elevation for whatever worth it is. As Madam said, it is very difficult to locate the leak, but liquor was still there in and around the baby. So we did every weekly TC, DC, and also we started our antibiotic. We could luckily pull her on up till 36 weeks, and we delivered her, and we presented this case in FIGO conference in Canada, and this was really appreciated.
Yes, I think that is really good that prolonging for such a long duration.
Yeah, but we have to keep the patient in the hospital.
Yes, we have to keep them in hospital for a long. Yeah, because even I had couple of patients, 3-4 patients, where we continued the pregnancy. One patient, she had IUGR also. We continued, kept her admitted for almost 6 weeks. And then at around 34 weeks, she developed a leak again, and there was some pain, and she was really apprehensive, and we took her up for a section. Now she's following up with a nice baby, doing well. It was a 1.3 kg. The patient is following up with her child. Baby has gained weight. Everything is happened good. So I think we need to draw a line how much to do. You know, if sometimes the CRP becomes positive, or you feel that counts are in the rising trend, because we need to even prevent the neonatal sepsis being occurring after delivery. We can't just prolong the pregnancy. So if you feel that you have given good steroids, and if you feel your NICU is a good setup to manage 1.3 or 1.4, that weight also is okay. I've seen 4 or 5 of my patients have gone home with that weight, and they are doing good.
Hello. Yeah, one more question. Any role of precautions like probiotics to prevent the infections?
Yeah. So now probiotics are actually, now there is an emerging thing that probiotics are, there are so many studies, you know, when we talk about probiotics, the vaginal probiotics, we see so many studies coming for bacterial vaginosis or any vaginal infection. So probiotics can be if patient who is having an underlying infection. So these infections also are cause of PPROM. So if you diagnose any patient in the ANC period, having a high chance like bacterial vaginosis, the discharge, you feel a foul smelling, fishy odor discharge, or a patient who is having recurrent candidiasis or a mixed infection with trichomoniasis, you can give them probiotics because they are really safe in pregnancy. And if you treat that infection, they will not develop PPROM later on. So if treating infection with probiotic has a good role, and there are many studies are there, but probiotics per se will not help, because the studies are usually pharma-based studies, whatever we see whenever we see online. So whenever they are used in conjunction with antibiotics, if you know that the patient is having a high risk factor or immunocompromised, there is no alternative to antibiotic. Bacterial vaginosis, we require metronidazole. It's not only the probiotics will help. Probiotics can be helped in long term just to prevent any subsequent other infection or anything. So when they are used in conjunction with antibiotics, they are really good, and we need to use them in early pregnancy so that PPROM doesn't.
Hello, madam.
Yeah, hello.
What is the recurrence rate of PROM, and what all we can do to prevent the recurrence in the next pregnancy?
Correct.
Yes. So what happens is that recurrence, if there is a strong history of PPROM, that can be because of the weak cervix or the constitutional or anything. And when patients are having a recurrence rate, the recurrence can happen around 10 to 15% of these pregnancies can complicate as PPROM. So these patients needs to be examined early. They need to register early. They need to find out if there is any local infection or anything happening. They need to be given, you know, if there is any risk factor which you have identified, that needs to be really tackled in that pregnancy early, and preventing infection, because infection becomes most of the commonest risk factor, or a risk factor related to their working pattern, or probably if there is a immunocompromised state like a diabetes or a GTM or a polyhydramnios, all these risk factors needs to be monitored in those patients if they are developing. So this patient becomes a high-risk patient, requires a good monitoring, good follow-ups. So all that, with that we can prevent and prolong that pregnancy till term.
Thank you. Any other queries from the delegates? Thank you, Dr. Komal Chauhan, for clarifying all the doubts which are very common in the practice and come across an encounter, because once there is a leak, a small hole like in a balloon, then everything is determined by a couple of days or weeks that we have to terminate this baby. And thank you very much, Dr. Muralidhar Paisar, the chairman of KCOG, for bringing in a talk and topic which is so relevant for most of us. And consistently, we have seen that in CPAP, all the topics and the speakers selected are of much clinical relevance to all of us. And I thank our chief patron, Dr. M.G. Hiramat sir, Dr. Vidya Thobi ma'am, the president-elect Dr. Bharti Rajshekar, and Dr. Nagaraj sir, who has logged in, and all the executive members and the members who have been part of this very interactive session. I also thank Mr. Arun from the KCOG office for bringing this platform and putting us up together. Thank you all.
I think Dr. Bharati wants to speak. She has raised her hand.
Yes, thank you. Thank you, Dr. Murali, for seeing my hand. Okay, and at the outset, I would like to, of course, as Dr. Murali has selected a very apt topic, which is of a day-to-day confusion for many clinicians in very dire situations. Thank you, Dr. Murali. And then I congratulate Dr. Komal for that excellent practical tips and talk that you have given us in the management of PPROM. We wish you all the best in your future endeavors. And on behalf of KCOG and myself, I request all the members who have logged in, the president secretaries of the societies, you would have received a nomination form from FOXI. Kindly nominate my name for Non-Communicable Diseases Committee. And also don't forget to vote for me. The elections will be in August. Dr. Komal, I request you to please support us from KCOG. Support me for the Non-Communicable Diseases Committee of FOXI as chairperson. Thank you very much, Rajeshri and Dr. Murali, for giving me this personal time.
Of course, you are the president-elect of KCOG, and we want you to be there in the FOXI as well, as because you have been working very hard at all levels, whether it is in IMA, whether it is in Hassan Society, winning so many times prizes for the society, and secretary for 2 years in KCOG. I think you truly deserve to be chairman of NCD committee. So we wish you all the best.
Yes, I need all your support, Dr. Murali. You need to tell all your friends to vote for me.
Sure.
Yes, all the best, Dr.
Your consistent work is quite an inspiration for youngsters, that over the decades that you have kept on doing whatever you felt like doing for the community and for the society and for the academic part. Hearty congratulations and best wishes, ma'am, and also to...
Thank you, Rajeshri.
Okay.
Thank you so much for your wishes, and all the best, Dr. Bharti.
And all the best to you, Komal, to become the vice president of.
Yes,
thank you, sir. Thank you so much.
Good night, everyone.
Good night.
Dr. Murali, good night.
Good night.
Yeah.